Results. Right ventricular outflow tract obstruction with normal size right ventricle. In the absence of right ventricular hypoplasia, the mortality rate for repair of pulmonary valve stenosis and intact ventricular septum is very low and approaches zero for patients with normal right ventricular function. The postoperative mortality and morbidity rates are higher for patients in chronic right heart failure. The 20 to 30 year postoperative follow-up is excellent for patients operated on before the age of 21 years. In all the patients, their late survival and functional status were poorer than in the control populations. Pulmonary atresia with intact ventricular septum. Neonatal palliation. Because of the different patient groups and various surgical methods to open the right ventricular outflow tract, comparisons of results is very difficult. Introduction of transcatheter relief of the obstruction improved the outcomes. A recent study by RVOTO of 33 children showed that in selected patients with patent infundibulum, percutaneous radiofrequency perforation of the atrial pulmonary valve associated with balloon dilatation was safer than closed surgical valvotomy and blood-causing shunt. Total mortality 15.7% and 42.8%. Similar results were presented by others. The authors reported a 17% mortality using percutaneous perforation in a more heterogeneous groups. In the past, surgical closed valvotomy carried 33% mortality. Agnoletti et al. Reported the result of the strategy currently employed in Paris in anatomically favorable cases. Patent infundibulum and non-right ventricle dependent coronary circulation catheter decompression of the right ventricle was first attempt. 39 patients, 2 deaths, 4 failures leading to urgent surgery with no deaths. At a median follow-up of 15 days, 21 patients required further surgery with 4 deaths. 2 more patients had a right ventricular outflow tract patch enlargement after the neonatal period. Repeated interventional catheterization was needed in 59% of the patients requiring surgery. The authors demonstrated the importance of further interventions, whether surgical or cardiological, required during the interim period. Right ventricular outflow tract patch. The results of right ventricular outflow tract patch enlargement in patients without right ventricle dependent coronary circulation were excellent. The authors emphasized the importance of patient selection for this procedure, which was based on coronary artery anatomy. Mainwaring et al. Reported no operative mortality for right ventricular outflow tract enlargement in 14 patients with a well-developed right ventricle without right ventricle dependent coronary circulation. Definitive repair. The initial morphology should direct the management from the beginning toward the biventricular repair or toward the fontan circulation to avoid attrition in the interim interval. The overall survival has improved over recent years. Earlier reports from our own institution show the 5-year survival of less than 50%, with 25% of children determined to be suitable for definitive repair. The latest multi-center study from the CHSS prospectively enrolling 408 neonats from 33 institutions reported a 5-year survival of 60%, with 52% of children reaching a definitive repair. This study could demonstrate the prevalence of 6 endpoints 15 years after entry into study. For 2 ventricle repairs, or is 3%, fontan circulation 20%, 1.5 ventricle repair, 5% heart transplantation, 2% deaths before reaching definitive repair, 38%, alive without definitive repair, 2%. Overall survival was 77% at 1 month, 70% at 6 months, 60% at 5 years, and 58% at 15 years. Among the risk factors for reaching definitive stages were right ventricle size, tricuspid valve size and competence, birth weight, date of admission, role of institution, prior atrial balloon septostomy. This study estimated that with current management, definitive repair could be achieved in 85% of neonates within 3 to 5 years after admission. On the basis of factors predicting repair pathways, they accept that 50% of neonates will be suitable for a two-ventricle repair and 35% will be more appropriate managed on a Fontan pathway. Richik et al. Demonstrated that using 3 different surgical strategies, two-ventricle repair, Fontan palliation, or heart transplant, depending on morphology, they could achieve the same survival in 3 patient groups. The role of 1.5 ventricle repair is more controversial. The advantage of providing a pulsatile pulmonary flow could be counterbalanced by a competition flow with the superior vena cava flow through the bidirectional cava-pulmonary connection. The behavior of this type of palliation during exercise is unknown. Figure 28.1, the nomogram for determining the Z value of the tricuspid valve from the measured diameter on the echocardiogram is reprinted from Hanley and etc. Thank you very much, and this sim has been end. I'm very happy to read books with you. Thank you.